Good morning. It's a real pleasure to be here at this meeting. So targeted therapies in Hodgkin lymphoma have really advanced the field enormously, as you all know, targets being CD30 for brentuximab vedotin. CAR T-cell therapy against CD30 is currently under investigation and thus far has not resulted in really durable remissions, but that is yet to be seen. And of course, targeting PD-1 in Hodgkin lymphoma really makes a lot of sense given the biology of the disease with the overexpression of PD-L1 and PD-L2. These are the approved targeted therapies in Hodgkin lymphoma. Brentuximab vedotin, nivolumab, and pembrolizumab. Listed here in tiny print is the indications and approvals in the US and EMA. So the first study we wanted to show was brentuximab, the first pivotal study in relapsed and refractory Hodgkin lymphoma. These were patients who had been very heavily pretreated. And as you can see, the overall response rate was really quite remarkable at 75%, with about a third of patients achieving a complete remission, with toxicity being predominantly peripheral neuropathy, sensory peripheral neuropathy that does tend to improve over time after the completion of therapy. After brentuximab was approved in the US in 2011, it was studied as maintenance after autologous stem cell transplantation in patients with relapsed disease with high-risk features, including relapse within 1 year of having completed therapy, primary refractory disease, and extranodal disease. And you can see with 5 years of follow-up, the progression-free survival in the maintenance arm is nearly 60% compared to 40% in the placebo arm. And those patients who had even additional risk factors, including going into transplant with less than a complete remission, having B symptoms at relapse, or having received 2 or more cycle regimens of salvage therapy benefited the most. So that then led to the question, could we improve initial outcomes by adding BV to or replacing bleomycin with brentuximab in the Echelon-1 study, which compared BV-AVD to ABVD in patients with stage 3 and 4 classic Hodgkin lymphoma. And here you can see the primary endpoint was a modified progression-free survival, so a typical progression-free survival plus any patient who received additional therapy at the end of the 6 cycles was considered an event. And you can see there was a modest improvement in progression-free survival of about 4%, comparing BV-AVD to ABVD, and that is held up over time with the 5-year follow-up and persists in both PET-positive and PET-negative patients. This led to the approval of this regimen in the US in adult patients with advanced stage disease. Then AHOD 1331 was a pediatric study done in the US that compared their standard regimen, AVEPC, which is a multi-agent chemotherapy regimen with less adriamycin or doxorubicin, given the concern for cardiac toxicity. They compared that to BV-AVEPC, and you can see there was nearly a 10% difference in progression-free survival at 3 years, with 92% in the BV arm remaining in remission. I will note, however, in this study, more than half of the patients received radiotherapy because patients with bulky mediastinal disease or those who were PET2 positive did receive radiation. So this is a major concern with this study, particularly in pediatrics. But if you look at the safety profile, it was really very similar across both arms. And then you'll hear about Paul's study, the HD21 BRCAD versus escalated BIACOP, which yields the highest progression-free survival we've seen in classic Hodgkin lymphoma in patients with advanced stage disease, including 2B with bulk or extranodal disease, with 94% of patients at progression-free at 4 years. The toxicity, this study had co-primary endpoints of toxicity and efficacy. The toxicity was less than with escalated BIACOP, but I will point out that there are significant amount of myelotoxicity, need for transfusions, and febrile neutropenia with BRCAD. Moving on to the checkpoint inhibitors, this was the first study of PD-1 inhibition in classic Hodgkin lymphoma, and you can see the overall response rate here was higher than 85%, with about 17% of patients achieving a complete remission. This was really groundbreaking and proved the points that targeting PD-1 in Hodgkin lymphoma is a very effective therapeutic strategy. These were the phase 2 studies of nivolumab and pembrolizumab in relapse refractory disease, and you can see relatively similar outcomes across both agents, with overall response rates between 65 and 78%, with the majority of patients achieving a partial remission, though for those patients who achieve a complete remission with 5-year follow-up of both of these studies, there do appear to be a significant proportion of patients who remain in remission without subsequent therapy. So this was a study comparing pembrolizumab to brentuximab in patients who had relapsed after autologous stem cell transplant or were not eligible for transplant. And you can see an improvement in progression-free survival with pembrolizumab at 13 months versus 8 months with brentuximab. The safety profile was as expected with these two agents. So this is the most recent study that was just published in the New England Journal 2 weeks ago, the S1826 study that compared nivolumab plus AVD versus brentuximab plus AVD in patients age 12 or older with stage 3 and 4 classic Hodgkin lymphoma. And with 2-year follow-up, the progression-free survival in the nivolumab arm was 92% versus 83% in the brentuximab arm. In addition, the toxicity profile with nivo-AVD was much more favorable than what was seen with brentuximab plus AVD, and I think this is going to be a significantly practice-changing trial. Already in the U.S., we're using this in patients with advanced stage Hodgkin. So in summary, brentuximab vedotin is a highly active drug that was initially approved in 2011. In the ATHERA study, we know that using it as maintenance after autologous stem cell transplant in high-risk patients improves progression-free survival significantly. Echelon 1 showed that BV-AVD was superior to ABVD, and the pediatric regimen incorporating BV had very good outcomes, again with significant radiation in both arms. And most recently, BRECAD really shows the best progression-free survival we've ever seen in advanced stage Hodgkin lymphoma. The PD-1 inhibitors, nivolumab and pembrolizumab, have very similar activity across patients with Hodgkin lymphoma with high overall response rates and some ongoing responses in patients who achieve complete remissions with single agent in the relapse setting. And nivolumab plus AVD really yielded very high progression-free survival and tolerability in patients over 12 and over going into elderly patients. The outcomes in elderly patients were really outstanding as well.